for what they drink. People who do drugs tell you exactly what they do. Right? So they tell you exactly what's going on. My thing is I'm always asking, when was the last drink? Because I know in about 48 hours I ain't gonna know you anymore. Right? Because those people that drink a lot, I had a patient, I don't drink, so if I had alcohol, I'd be feeling crazy. But I had a patient one time that told me he drank a suitcase. And I was like, what? How many beers is that? I had asked him, I was like, how many beers is that? He said, that's 24. And I was like, because in your head, you're going like, that means that you drink 48 beers a day? You know, that's what we talk about. That's the general thing. And I'm thinking, who has time to live if you drink that much beer a day? So I'm thinking to myself, literally when I'm standing in front of him, what was the last time you had a beer? Because if you drink 24 a day, it may not take 48 hours for you to get crazy. I don't know how people do that. That's a lot of beer, right? So, but people usually tell you half of what they drink. But we see it with UTIs, electrolyte imbalances, and which electrolyte imbalance I'm looking for? So crazy folks, you're always in their house. So our post-op patients, and ICU is one of those because something is always going on. Patients don't sleep. You know, somebody's bell is going on. Even if you got it quiet in their rooms, there's something going on in ICU, so you can see those patients. So how we prevent this, of course, is try early recognition, monitor our patients' neurologic status, protect them, get family, reorient, all the stuff you know how to do for patients. The one thing I do not like up here, and I know that is true when you look at a textbook, it says to give a patient a neuroleptic agent. Never in my life would I order that for a patient. And it's mainly because Haldol has a lot of side effects that go along with it. So that used to be olden days. Now what you see people get is Ativan, right? So when you have patients with acute confusion, that's what you see. This is the textbook though, it's a neuroleptic agent. So that means, but Haldol is one of those things that causes a lot of problems, extrapyramidal symptoms, that kind of stuff. So it would never be first line therapy for me to order something for that for a patient. So you want to encourage family and support, but usually it's a transient thing. For a lot of times, you get patients back to a more normal routine, and this kind of lifts them. So we have a question. We have a client recovering from ARDS with a waking alert that has residual fatigue and generalized disease. The client's current vital signs are heart rate of 83, blood pressure 104/64, respiratory rate of 25, SpO2 of 92% on 2 liters. Which vital signs requires the RN to take action? So this negative focus question, because if you're taking action, which of these things worries me? Is it my heart rate, my blood pressure, my respiratory rate, or my SpO2? My respiratory rate. Now, when we look at this, the patient recovering from ARDS, that 92 is awful on 2 liters, but that's expected for this patient. So remember that things that are expected, get rid of those. And that's only because of that diagnosis with that patient. I may only get them at 92 on 2 liters. That's awful, but that's all that I may get for that person. But tachypnea tells me something's happening with this patient. So you have a client is admitted with a 2-day history of cough, fever, and fatigue. The medical history is positive for type 1 diabetes and upper respiratory infection. Vital signs are a heart rate of 109, blood pressure 102/58, respiratory rate of 24 breaths per minute, temp of 104, SpO2 at 92% on 2 liters via nasal cannula. Which order has the highest priority? So positive focus question, what do I need to see first in this person that has these symptoms? Because what do you think is wrong with them? Sepsis. So that temp is telling you that's a septic patient. They meet SIRS criteria, as we call it, that you're going to see happen with this patient. So it's to do my IVs, blood cultures, antibiotics, or serum lactate and glucose levels. What I'm going to do first. So we're going to do blood cultures first. One of the things to remember for your life as a nurse, blood cultures come first with all of these questions. But even if the doctor wrote blood and sputum cultures, you do not hold your antibiotics if you can't get sputum. Blood cultures is the most important thing for you to get for a patient. Sputum may happen just then, or respiratory may come in and use one for us, but sometimes you have to wait until early morning because that's when the person is able to cough up all manner of evil when they lay down at night, kind of thing. Now the lab that you see at the bottom are things you're going to draw on the patient. That helps you confirm sepsis, right? Because serum lactate level is high, pH is low, but they're also positive for glucose. So those are things that help confirm, but those are going to be things that require physician order, right? So we want to make sure we're doing those things first. So a client with a history of uterine fibroids had a cesarean delivery 12 hours early and delivered healthy twins. At shift change, the RN assesses the client and notes shortness of breath, cool extremities, losing blood from the incision. Based on the client's presentation, which nursing action has the highest priority? What are we gonna do first with this person? So what do you think's going on with this one? DIC, because that oozing of blood kind of tells me, hey, this is what may be happening. Plus, it's an OB question, right? Remember, so I told you DIC, sepsis is one of those common things that causes it. The other thing is OB. So are we going to assess the temperature, notify the healthcare provider, clean incision site, or draw labs? This is notify the doctor, because you can't change this. Now, the labs on the bottom are what you're going to end up drawing for the patient. But the first thing I need to do is call the doctor, because that's a change in patient status, change in patient condition. I need to make sure I call about that. So we talked about ABCs for most things, but remember when it's a patient who is in arrest, it's CAB, chest compressions, or circulation, airway and breathing, and high quality compression is what saves people. All right, so that's what's important for us to do, is to make sure we're doing those quality compressions. Now, long time ago, we used to just have your CPR update once a year. Your annual training was what you did that. Now you know we do RQIs every quarter when you work in a hospital. So you'll be able to do those, whatever shift you work. You don't have to come in, especially for a skills fair. But the reason that they're doing that is saying that if we refresh staff's ability to do CPR, we save more people. And truly, when you're in a code situation, the quality of your CPR goes down in about 4 minutes. So 2 cycles, you're tired. And if you've ever had to do compressions on somebody, you notice that's why we always, rotate people out in a code situation. But you want those compressions to be between 100 and 120 compressions per minute. And this is the CPR, the question I said I think is going to be ordering is going to be this one. So it's in your book, but if you're a visual person, take a picture, because this is the one I think you're going to see about putting things in order. Because everybody has to know how to do CPR. So that's something they can ask you about. So of course you determine our responsiveness, check for a pulse, activate your code team, call for an AED. You're going to do CPR BCLS guidelines. And that's the thing to remember. Somebody's going to ask you ACLS, because that's different. It's not that you don't do the same. The first part of it is always the same, but whoever's ACLS qualified then calls the code when they come to the code situation. So most people who work on telemetry floors, most people that work in ICUs, most people that work on rapid response team are ACLS qualified. So when they arrive, then they take over the code. They're going to tell you what to do for the patient. So don't freak out. Don't think, oh my God, I don't know what to do. You may be standing there pushing meds, because you can do that. So they'll tell you what to do for the patient, but that's going to happen during the code. So initiate your compressions, and of course we know that's 30 to 2. I'm gonna do those compressions, but you get a breath. Just skip all over that in real life. I don't know. All right. So once the defibrillator or the AED arrives, you want to do a quick look, because if it's a shockable rhythm, the sooner you terminate that rhythm, the better for the patient as far as your outcomes go. So as soon as it gets there, we're going to do that. If it's not a shockable rhythm, or you shock the patient at that time, always remember to say, I'm clear, you're clear, we're all clear. You look, because twice in my life I've had to code not only the person in the bed, but the person who falls on the floor next to it. All right, because somebody's in contact with the bed, or something on that person is in contact with the bed. Because remember, when you deliver a defibrillation to a patient, they needed it. These people standing next to the bed don't. Right? And so if you get it just right, you end up with a person that passes out and their heart may stop. All right, so for all of you who have never had that happen to you before, if you watched the Patriot games a couple of years ago, you saw somebody happen on a field. He got hit just at the right time, and so he went into cardiac arrest. Now the bad part about it, I'm not even watching the game. My brother called me and said, "What's going on?" I said, "What are you talking about?" So I turned to the station, and I see them doing chest compressions on this guy for a long time, which made that so usually you don't have that for young folk. So I already knew it was bad. What was going on with it was not the usual thing that we see going on with that. But what was interesting after that went on, you found out how intricate it is about how they coordinate stuff at football games. I didn't know that until they tell you. They have spotters down on the field, spotters on each box up in the where they're, where the rich people live, in the boxes over there. So they're looking down at the thing. So as soon as he fell, that's why they were out on the field so quick. Because when you see people fall, there's certain people you see fall and you know it's bad. He was one of those you see and you know that something is happening. When you have people that fall and don't put out a hand, that's when you know something is bad. So for real old people, I don't know if there's any of them in the room, but we had an issue like that with a patient who had a spinal cord injury years ago playing in a football game on Thanksgiving Day. So Detroit Lions lineman got hit, and you just saw him go like this. Normally what you do is see him break his arm because he's a big guy, and he falls on his arm, but he just went flat. And so when they came back twice for the breaks, he was still on the field, so you know it's bad. Because usually they get you up and you got it. That's what the guys are doing when they go to the back. So you know, but he had a C4 injury from playing football. But he walked out of the hospital. They did something for him that had not done before. They put ice saline around his spine. And so he didn't have a break, he just had a pinching injury kind of thing. But he ended up walking out of the hospital. He walked like Frankenstein, but he was walking. So that's a good thing. All right? So we're gonna resume CPR on the patient. So this one is the one I think they're gonna have you put in order. So now, of course, this relates to children. So you have to think about the guidelines that we do for them are just different placements of where we put our hands, and then the amount of volume when you're doing their air with these patients. So the indication for adults when they when you have to perform CPR is usually cardiac in nature. The younger a child is, it's usually something else. So when you talk about neonates, it's hypoglycemia, hypothermia. Children is usually respiratory related that we see associated with that. So your guidelines are only changed just because of where you put your hand, where you check for your pulses, that kind of stuff. So this is just the update on what you're doing for kids, the depth of compression, and how much, where you calculate your pulses, and then how you get your breath. I get it together with you. So this one is that question itself. I'm not gonna have you go through this, so we just looked at that one. But this is just putting them in order about what you do for that patient who is, that you have to resuscitate. And like I said, I think this one is the one that's gonna be that they have for ordering, because everybody has to know how to do CPR. So this is the order in which you would do this: assess unresponsiveness, assess for a cardiac pulse, activate the code team, move the client to a flat position. You always have to put the patient on something hard in order to get the blood out of the heart. That's part of why when you're doing the compressions, yes, you want the heart to refill, but you also have to get that blood out, so you have to have if you don't have a backboard, you just put them on the floor. Begin compressions. That I have to do CPR on the floor too. It hurts your knees, but you just go through the cycles and you get that person up. Open the airway, give your 2 rescue breaths, and then of course we're going to do our quick liquid paddle. So in disaster management, of course, we're in Florida, so we have these issues going on. Thank goodness we haven't had a big storm this year, and I keep praying. I know people in Tampa pray. I don't know about nobody else in Florida, but we've had hurricanes that always come right to Tampa and always go somewhere. And so I keep saying, thank you, Jesus, that somebody's praying. And but Katrina was coming, and she just made a little joke and ended up that way. Now, the brother that works for, that's the engineer, works for the electric company. This is the first time in Tampa's history they were going to turn off all of downtown, because saltwater intrusion is worse than if you turn things off ahead of time. So I live not far from downtown. So he was like, you and mom have to move, because my brother was alive at the time. I'm like, what are you talking about? Nothing ain't coming soon. And he said, yes it is, it's coming right here, we're getting ready for it. And so he said, well, you know, if you put the house up on, the furniture and all this stuff on blocks, and like the house is up off the floor for, 4 feet, because you have to come up. I ain't worried about none of that. I said, God, don't protect my house, kind of thing. And literally, probably about 12 hours after that, the shift came, so she ended up in New Orleans. Now, the bad part about this, of course, we've had hurricanes after that fact. I think the one that has come closest to Tampa that has caused problem is Elena, so that's a long time ago. We actually had patients at the hospital where I worked, St. Joseph's, that were evacuated from Tampa General, because Tampa General sits on an island, which is stupid, but You got a hospital with 1,000 people that sits on an island. So if the bridge is gone, where are you gonna go? Okay, I don't understand it. When they built new stuff on it, the generators are on top of the buildings now, so that's gonna help a little, but that's stupid, I'm just saying. Okay, but it's not even a real island, it's dredged up, so I know one of the days the sea is gonna take it back. Just saying, you know. I'm crazy like that. We have areas in our neighborhood that used to be, in the area that used to be like swampland, and they got whole things on them. I said, Lord, if we ever have a hurricane, all that's going back to the sea. Just saying. I just worried. But these last hurricanes that we had, I don't even remember the names of them, but I remember, and you guys might remember this only because you got backup of traffic. Plant City was the only place you could get help after this last hurricane that we had. So you know, Plant City is between Tampa and Orlando. So they had backups on I-4 that were like 6 miles on either side, trying to get off on this one exit, because that was the only place you could get help. Every other side road, like 98, 92, were all filled with people trying to get to this one spot. So what we hopefully learned from that time is that you need to set up more things for after the fact when these things happen to patients. So we've only had, or it happens in our community. The thing that we've had first actually in the country, because Florida's crazy, we had the first anthrax that was sent in the mail in South Florida to the National Enquirer. That was when we first had that. So most of the time when you see questions that have to do with biologic agents, anthrax is the thing they ask you about, because that's the thing we've had in the United States. In other places, it's all other kind of stuff. You know, sarin gas, all this kind of thing. You know, we do have a vaccine for anthrax. Erythromycin treats it. And anthrax is something that truly exists in cattle. People used to get it from eating infected cattle. That's how people would get it. But now we have these fools that make it in powder and aerosolize it so people can die from it in solutions. But that's what people do. So more than likely, you will get something with a mass disaster. Now, as part of your education, did you guys participate in a disaster drill? No. Because we had a big one. All right, so we usually do, in the springtime, we have a big one. We have 500 casualties, which are usually high school students that are in the goulash. They just love it because they look like Frankenstein monster. And then you feed them on top of it. But we get to go out and triage them. So the medical schools, all the nursing schools get together and we do this big triage. And it helps you figure out that you don't ever want to be part of that in real life. But this year it was a plane crashing into an apartment building. That was the thing. So we had a lot of burn patients kind of thing. But they do that in order for us to get ready in case it happens. And of course, you guys really did have it happen with the pulse shooting, right? So these are the kind of things we try to get ready for. Hope you never have them, but those are things that we get ready for in that event. So we go through that primary stuff about education and training. Secondary is the triage, and this is the part that, you know, is kind of hard for outside people to get. When you have a disaster, you're really sitting there thinking about who I can save. And those people that I can't, I just step over. And I know that sounds awful, but if you cannot save a person, you got to move on to the next thing. So when you're looking at NCLEX questions that may ask you about disaster, anybody that has agonal respirations, anybody who has cyanosis, anybody who has fixed dilated pupils, you cannot save them. Keep moving. Go to the next one in the group. All right? So agonal respirations precede death. That's what you usually see in a patient. All right? Cyanosis, we know that's not early, right? That's always late that we see out with a patient. And fixed dilated pupils tell you nothing going on in the head. Those are organ donors kind of thing. So you start moving to the next person. And I know that sounds callous, but when you got 600 victims, guess what you got to do? That's it. You have to make a decision about what's happening. So our goal is to maximize our survivors, of course. We look at this color-coded, and then we do some evaluations about the patient. So you're looking at respirations, circulation, and mental status, and we code them by red as a life-threatening injury. We have yellow that has systemic effects. Green is our walking wounded. And then black are those people that are dying or deceased already. So we have to make that decision when we're going through and looking at our disasters. So you have 4 clients arrive in the emergency department after an explosion. In which order should they be assessed? You gotta put these people in order, so it's an ordering question. You had a 70-year-old who is complaining of pain level 8 out of 10 from a hand burn, a 35-year-old partial and full thickness burns to anterior and posterior chest, 25-year-old with superficial burn to the right anterior arm and lateral chest, a 42-year-old with partial thickness burn to anterior lower extremity and confusion. So who am I gonna see first? I see number 2 because large body surface area burn, right? 18 and 18, anterior and posterior chest. Who's next? Number 4, I have that 42-year-old who has a partial thickness burn, but they also have confusion, systemic symptom associated with that. So who's next? Number 1. All right, so people go back, well, how come number 1 trumps number 3? All right, now it's a 70-year-old older person, but the real reason is where the burn is located. When you have a patient who has a burn to the hand, the foot, the head, or the perineum makes it a major burn, regardless if that's the only thing that's burned on the patient. All right, so in this meeting, because if you got a person with a hand burn, if the finger and thumb is burned off, they can't do stuff. Dexterity is affected. You have to, and when you have a burn injury to the hand, each finger has to be wrapped separately, or you end up causing problems with movement and all that stuff after the fact. Bad stuff when you talk about hand burns. Think about your patient has a toe cut off. What do we have to do? Send them to therapy because they have to learn how to balance. So a burn to the foot is going to do the same type of thing when you're talking about a patient. Also with the locomotion piece, they can't get up and move around. Perineum, we talk about for infection. And then of course with your head and face, you're thinking about could be inhalation injury secondary to that, but also the tip of your nose, your ears, and that kind of stuff. Even though they get blood flow or not well, blood supply, so if you have patients, that's where patients can have necrosis. So that's gonna be number 1, and then our person in number 3.
Other aircraft.
Okay, so 2, 4, 1, and 3.
It would have been other aircraft in my own.
So the RN is assessing clients at the site of a community disaster using the color code system for triage. Which client will be tagged red? All right, so we know that's the most serious patient and what we're worried about, right? So we have a client with a large head injury who is bleeding, open chest wound, cyanotic skin, no capillary refill, agonal respiration. What color is that? Right, we just gotta walk over that, right? So a client with bruising and swelling of the right forearm, assorted lacerations to the face and neck, dry skin, normal capillary refill, and a respiratory rate of 18. You gotta think about that one. So a client with scratches and scrapes to the head and face who is limping and helping others at the scene. Green. And our last one is a client with open wound to the abdomen and deformed right femur, pulse 125, delayed capillary refill, respiratory rate of 32, who is moaning. Yeah, that's our rate. So that other one up there is yellow. But when you think about this one, that open wound, always that's a person already that you got to think about peritonitis after the fact. Remember, you're a CSI now, right? So you're thinking about what's going to be the stuff I got to look for later. This is the person you got to worry about overwhelming infection, no matter what you end up doing with them. You got a deformed right femur, so that lets you know there's a fracture. Poor capillary refill tells you I'm already having some decreased perfusion in this patient. They don't have vital signs up there except for their respiratory rate, but you can just bet that blood pressure is low in this patient. So that's the person I gotta worry about on the other side. So with bioterrorists, like I said, and anthrax is probably the thing you're gonna see most often associated with a question if you get something about it. And they have a couple of questions here. So one is about a patient who, that's in the emergency department, suspected of anthrax pre-decontamination. So which transmission precautions should be most appropriate for the client? Now, one of the things about exposure to chemical stuff, people are not treated in the ER at first. They treat you in the parking lot, all right? So they try to figure out what it is you got and get it off you, and then we try to worry about what goes with you, what we have to do with you. Now, for us in the U.S., sometimes we don't have an appreciation of how good we have it until you go visit some of the other places in the world where people have to do stuff about this every day. You know, during the Republican National Convention that was in Tampa, that was the first time in my life I had been around people with guns on the corner, every street corner of downtown. There were people with AR-15s every day. That was the weirdest feeling ever. Now, I've been to other parts of the world where people do this, like Israel and that kind of stuff. I've been there. to see that, but I never thought I'd see it in the United States. But I saw that during that whole thing that was going on. The same issue for us in nursing when you talk about biological weapons. Now, of course, half the hospitals have been destroyed now, but I went to Israel to visit hospitals. And one of the things that you saw was they would have in their emergency room where they could treat a patient for everything short of surgery, because they would close off the patient in the room. You would figure out what they had. You had x-ray machines, labs where you could do your lab stuff, all of that in a room, because that's what they live with every day. Because you don't know what people are gonna do. So this is one of those things, when I get to this question, it makes me think about that all the time, because I don't really worry about it until something comes on television and go, oh my God, somebody's doing stupid stuff, right? So what are we gonna do for that patient that has anthrax? What are those isolation precautions we're gonna use? So airborne, contact, vector, droplet, and standard.
What is
Vectors like disease, bugs, animals.
Y'all see this?
That's the airborne
Alright, so
contact.
it's gonna be airborne, contact, and standard. Now the good thing is, like I said, most of the time, if this is something that is a cutaneous exposure, anthrax can be in the skin or inhaled. So sometimes we have it on skin. Of course, that's a contact person you gotta worry about. You don't worry about people just getting that. That's more of a contact
No,
issue.
why is
But if it's aerosolized, that's the problem you have. Because when you breathe it in with spores, that's essentially what you have. So then we have the same question, but it's related to smallpox. Now, the last time that we've had smallpox out in that actually occurred in nature kind of thing, where you saw an endemic outbreak was in the 80s.
It would be
So late 80s that we
chickenpox.
had.
Chickenpox.
Now what's crazy is we're starting to see the plague. Y'all did see that, right? We're seeing stuff that we thought we got rid of years ago that's back. Just telling you, it makes you nervous.
What about
Now, all this stuff interests me, but I'm scared as heck.
droplet too?
Right, because I'm going, man, I have to work for the CDC and go places, and I'm like, well,
Droplet is like flu, so I think they'll be like.
because you know what's going to happen.
Basically, airborne.
Before it's over, I'm going to end up with the trick, I just know it. So I can't do that. But I find all of that interesting about disease and all that kind of stuff. It scares me, because you never know about crazy folks. Right? And I remember this whole thing. I remember going to school one day, we were all in the cafeteria, they lined us up, and we got a smallpox vaccine whether we wanted it or not. So when people talk about this whole thing about COVID vaccines, I'm like, what? We didn't have a choice. They just put us there, and people shot me with a gun, and I was like, what's wrong? All right. So we see the same isolations here as well. Airborne, contact, and standard. So it's like, really, infection control is something we really have to get back with again. So RN is caring for a client in shock of unknown etiology, observes the rhythm below on the monitor, which is RN's priority intervention. So what is the first thing I need to do for this person? Because I see this come on. What am I gonna do? We gotta check for a pulse, because remember, assessment guides interventions, right? So that's why you gotta do assessment, because that's gonna be how you treat this is gonna be dictated on whether the patient has a pulse or not. So we're gonna see if that's real on top of it, because you see that on the monitor. The other thing about, I have people that always want to shock the patient, and this one actually is something you would shock. It is a shockable rhythm if they don't have a pulse. But the other thing is that that's the highest energy. You start at 200. You'll be 200, 300, 360 when you're talking about the
I want to see jerk.
Hesi was shocked. All right, so the RN admits that client was suspected early DIC. Which symptoms may indicate early organ ischemia? So which of these things tell me that something's going wrong with organ systems in this patient? Slight gingival bleeding, alterations in mental status, petechial hemorrhage to the chest, slight decrease in urine output, bluish discoloration of fingertips.
I'll take on number 4. I don't know about. I'll take on.
Not 5.
And of course, it's select all that plasma.
No, I think it'll affect the urine.
I hear y'all going.
Let me see like maybe 1, 2, 3. Do
So
you
think
see
about
that?
organ
Organ
systems.
ischemia?
Number 2, brain. Number 3 is liver. Number 4 is kidneys. All right? So it's 2, 3, and 4. Because you're talking about organ systems, what's causing that problem. So if you take out your liver, that's the clotting factors. That's why petechiae is happening in your patient. Alright, so now we have a next gen question. The RN is caring for a client who has a new anticoagulant prescription, warfarin 2 milligrams PO daily, and you're likely to see that on a test because Coumadin is common. Anticoagulation is something that's common, but it can kill you. So that's why we ask you about the new question. Teaching plan with the client regarding the use of warfarin with dietary restrictions for foods to avoid. Which vegetable would the RN instruct the client to avoid while taking warfarin? Select all that apply.
One.
So what did we tell them to avoid? Dark green leafy vegetables because they contain vitamin K. Reverses everything we're trying to do, right? So which one?
Number 3.
1, 3, 4,
It's green.
6, and 8. All right. Now I love collard greens. I love broccoli. No, I don't like broccoli, but I like collard greens. I love Brussels sprouts.
Broccoli and
Yeah,
chicken.
that's one that people like. I love it, right? But I can't get used to that kale. I don't care how long you cook it.
Oh yeah, colorless. You guys call it colored green, we call it colorless. In the Caribbean, we call it colorless. Colored green. I think yours guys taste weird too. Colorless.
Not like,
Alright, so this is
yeah, colorful, but it's okra. We call it okra.
sepsis.
But the okra is
This
like a
one
green thing like this.
You will never forget about sepsis. You'll be singing this crazy song, and you'll never forget about sepsis. You see how many people die every day, right?
I'm bringing sepsis back. Those microbes unprepared for my attack.
No, they're not.
Check these broad spectrums I've got on the rack. I narrow therapy by culture track. Give them all the bosun. Something big. 4-liter bolus and you're still the same. I start to
Everybody, you see all the nurses out there, what they would be moving. You know, if I say anything to Johnny, nobody will say nothing.
Now, the thing about it is, that's a crazy little song you'll never forget, you know, about
Get the sexy on.
And when I was talking before about service criteria, this is when you have 2 or more of these things, you think about a patient with sepsis. So altered mental status, they have a temp or hypothermia, but remember when the temp is low, that's bad, that's a very ominous thing about a patient. So they're tachycardic, they're tachypnic, that when they're talking about the shift voodoo, you're looking at what is happening because of the bacterial infection. So the white count is either greater than 12 or less than 4, because that's a neutropenic patient that you're talking about, less than 4. The bands are 10% with a less shift difference. Now nobody's gonna ask you to ask about the shift part. That's a physician thing, but it lets you know that that's bacteremia. So that's basically what we're looking for in that patient. So 2 or more of those think sepsis, and plus an infection think sepsis. And remember in the song he was singing, I gave you 4 liters and there's no change in your blood pressure. That's the key that you usually look at, because if you have a shocky patient and I'm giving you volume, your blood pressure should go up. And when it doesn't, you start looking for where the infection's coming from. So a little ditty song that you never forget. And unfortunately, we have more people with sepsis, so that's been a problem. All right. Chapter 5. Okay.
Favor.
Sure.
Can you grab me?
Losing my mind.
My legs are just in a perfect position.
Your mind is clear.
All right, so with this one, we have
Merci
oxygenation,
beaucoup.
ventilation,
Oh,
transport, and And then chapter 6 has to do with GI stuff. And that one I actually just give you some information between 6 and 7, only because chapter 6, the majority of people who are nowadays that you see admitted to the hospital, yes, we treat their GI problems, but to admit them solely for GI is rare. There's some other stuff there in the hospital. Chapter 7 is your endocrine and reproductive stuff, and your endocrine stuff is going to be diabetes, because diabetes is common. But we'll talk about some of those other ones. I give you some stuff to look at in that one, and then we get on to 8, and then we start getting to some of the people ask me about that they need the PD stuff. That's the stuff we do afterwards, but this is all the med-surg stuff that's in the middle. Some more than others. So this one I can describe all the stuff that's probably in the next 4 slides, just by looking at this particular slide itself. Remember, a patient has a chest tube to allow the lung to re-expand. So if I remove a part of the lung, or a patient has a pneumothorax, that kind of thing we're gonna put in this chest tube so it allows the chest to re-expand. When I saw this picture of a pleurovac, I said I haven't seen these in ages, because most people use atriums now. So it's this, but it's still the same process. Has 3 different chambers that you're gonna see in the chest tube. One is gonna be the water seal, which doesn't allow free air to come into the chest. One is gonna be your suction chamber where you have control. This one actually is a dry suction. If it was a patient who had wet suction, or as we call it, or the ocean when you're looking at your atrium, you would actually have another section here that's gonna be on this side, and it would have graduates and numbers here up to 20. So you fill that with water. But the suction control allows you to dial in suction. So -20 is what's in your chest, but if I have a person who's had recurrent pneumothorax, I may need that 25, 30 in order for that lung to re-expand. Sometimes even higher in the patient, you may have to go with that. So it allows you to actually dial that suction. The last chamber over here is your collection chamber. And pretty much you can tell why a patient has a chest tube about where it's located. Air rises, so chest tubes for pneumothorax, 4th intercostal space. Drainage drops, so if you have a patient with chest tubes that are 6, 8, 10 mediastinal tubes come off the bottom. Those are patients that use that 10th intercostal space. Those are people that are there for drainage. So in your head, just by looking at where the chest tube is, you know why the patient has it. Okay? So what we want though is no free air to come into the chest. And then this is gonna be, if it's a pneumothorax, not a lot of drainage there, but if it's put in for drainage, you're gonna see a lot more that's there. Every shift you're gonna mark and see how much comes out. You never want more than 70 an hour coming out of the chest tube. All right, so when a doctor puts a chest tube in a patient, if it's a part of a surgical procedure, they just do it. But if you have a person that's on your floor and the doctor says we need to put a chest tube in this patient, you have to get a consent form signed. And remember, you have to do that before you give them medication, right? So if the doctor's gonna do that at the bedside, it's not for the fate of heart nurse. Chest tube is not easy to watch somebody get put in. And so if you are a fate of heart person, send somebody else. But if you do faint backwards. Not faint in the sterile field. None of that. So what happens is you ask the doctor, can we give this patient some medication? I like vitamin V, Versed, because Versed, if you give it to the patient, they're gonna go sleepy and then they wake up, they just have this. If you give somebody pain medicine, the patient remembers that you helped the doctor do it. They will remember all of it, okay? But Versed, oh, we go to sleep and be happy, and then they wake up and go, oh my God, what's this? All right? That's the kind of thing, yes, I'm just saying, unless it's a contraindication, it's the better thing to do for patients. Pain medicine remembers everything. So when you go in, you're gonna gather all your equipment, you're gonna need this chest tube. You're also, doctor will tell you what size tube they want for the patient, and then they're gonna get a chest tube tray. They're gonna clean, you give the patient the Versed, so they have, ooh, they're happy people. You turn them on their side, almost knee chest position that spreads the ribs so doctor can put in the chest tube. So when he or she is over there getting their stuff ready, they're gonna have that chest tube tray, they're gonna clean off the chest wall of the patient, they're gonna do a scalpel cut, they're gonna put their finger in there. That's usually when I have students faint the first time. Because I have to go pick them up when this happens. They go like, your student fainted. I'm like, okay. So and it's one of these things that they usually do. So they put their finger in there. What they're doing is separating the fascia. So that's what he's like, ugh. You know, your finger goes down about an inch. So you go like, what are you gonna play? You know how they, I get crazy. So I think that's what students are doing. Right? So they're gonna do that. But then the doctor's gonna need the chest tube. So a lot of times they haven't put it on the table already. You're helping. So you're gonna open it for them. He or she's gonna tell you, just take the top off and drop it in their hand. They're gonna take it from you. And then they're gonna shove it in the patient's chest. That's usually the second faint. Because the pushing sometimes pushes the patient, the bed, and you, because they have to get enough force to get it in. Right, so that's the second time I have to go pick somebody up off the floor. So the only thing that's holding it in is a purse string suture. So you think a lot, even though all that elastoplast they put on the patient, the only thing that's holding it in is like a drawstring on a purse. So when they put it in, you might get some subcutaneous air, normal. What you don't want it to do is keep growing, right? So when you get a little bit, you notice that can happen, but if it's a lot, it can keep growing until it goes into the phase all, and people look at you like, what did you do to mom? When they come in to see them, because they're gonna be puffy. The only thing is they don't have bruising. So you didn't beat them up because you see that, right? But family freaks out when that happens. Now that means I may have to put another chest tube in the patient because air is just coming up here. That's not what I want it to do. I want it to go into my device. So we monitor that. Okay, so you always want to make sure a patient has pain control. PCA is fantastic for patients who have chest tubes because then they can control their own pain. But you need to, this person's gonna still have to keep breathing, coughing, and looking at you like, shut up, put something in my chest. I ain't trying to do that. So that's why you have to make sure they have pain control. So monitoring, when you're looking at the changes in the pressure in the chest, you're looking for what we call titling. That's gonna be done in the water cell chamber. When a patient takes a deep breath, you're gonna see that ball go up and down. That's normal. Constant bubbling in the water seal is abnormal. Okay, that could indicate a leak that you have with the patient. So you may have, just a momentary, bubbling there when a person does a cough, but it should not ever be continuous. Okay, so you never want to see that happen in the patient. And just for me, I never, chest tubes have a clamp on them just like a Foley catheter. I never use that clamp if I'm trying to check and see if the patient has an air leak, because it's easy to forget you left it clamped. So me as an old nurse, if I have a patient with a chest tube, I put 2 Kelly clamps and tape them to the wall. And so when I take one down to use it to see whether there's an air leak for the patient, and I always start close to the patient because if it stops, you know it's the patient and not your device that's causing the problem. But I look up on the wall and I don't see the second one, so I know where it is. I need to take it off the patient. But you can leave that clamp and forget it until your patient develops respiratory distress or attention pneumothorax, because you're not seeing that visual piece that goes along with that. So that's just me. I never do that with a patient as a chest tube. So the next few slides are all that we just talked about, right? So it's in your book, but just know that this is something that you may see in patients, especially after thoracic surgery, chest injury or chest trauma patients, or if you have a patient has a pneumo. And young men who are thin and tall and smoke are usually the people that have pneumothorax. So those are people that you kind of think about with that particular. Okay. So I kind of talked about both of these. Just know if you have a patient who dislodges it, you're gonna cover with a dry sterile dressing. Generally, if you have a patient that pulls it all the way out, just pull the purse string, suture together, put a Band-Aid on, and get a chest x-ray. Generally, we don't take chest tubes out unless you have less than 50 mLs of drainage for 3 days at least, and then we take them out. Because if you're still having drainage, I have to put one back in. So we kind of look at if the lung is re-expanded, that kind of stuff. And you'll see people, that may have them for a long time, especially if you have a person that actually has water in there for your suction. You want to turn your suction off and actually look at the level of the water. Because when it's bubbling, it may look like it's 20, but when you turn it off, it's only 16. That's why the lung hasn't re-expanded. So a lot of times it's us that doesn't realize that kind of stuff going on. And you only need a gentle bubble, because people act like they cooking pasta when they're doing those chest tubes and wonder why your water evaporates. That's why. You only need a gentle bubble through there and it's still gonna do the same thing. All right, so the RN is precepted, the RN orientee who's caring for a client with chest tube. The client is 12 hours post-op from a left partial lumenectomy. Which assessment will the nurse advise the orientee to immediately report to the healthcare provider? So we can select all that apply. And if you're immediately reporting it, this is a negative focus question. So which of these things should not be happening to the patient? A pain level 6 out of 10 on the left side, tracheal deviation toward the right, drainage from the chest tube of 50 mLs in the last hour, oxygen saturation of 90% on 2 liters, vigorous bubbling in the suction chamber. Tracheal deviation tells me what? That's a attention pneumothorax, right? So that's a medical emergency, right? Because not only are you having this person that's tachypneic, what is going to get cut off? Because what sits there? The heart and 2 other vessels are there. The aorta and the vena cava. So you're cutting off not just the heart, but all circulation everywhere when you talk about a patient has attention pneumothorax. So is that drainage okay? Yeah. How about that oxygen saturation?
No.
Where do I want my post-op patient? 95% or greater. And that vigorous bubbling in the suction chamber should not be happening. So 2, 4, and 5.
We passing the NCLEX.
So the RN palpates the crackling sensation around the insertion site of a chest tube in a client who had thoracic surgery. Which action should the RN take? So positive focus question, what am I going to do for this patient who has that crackling sensation, also known as crepitus or subcutaneous emphysema, you may hear some people say. So return the client to surgery, prepare for insertion of a larger chest tube, increase the water seal suction pressure, or continue to monitor the insertion site. You want to continue to monitor. Now I'm telling you, air rises, so you're going to see if it's there and it just keeps going. You're going to see their neck get fat, their face gets fat, it'll shut their eyes, because they can't even open their eyes, they're so edematous from air. I had a patient that a student was taking care of once that was so bad. Patient had not just that in his face, it was all, I don't know what condition he had, but he had all these blebs, I think, that were rupturing. And they ended up doing fasciotomies on him so they could release the air. He had like 6 incisions on his chest because he had so much air going on. That was the weirdest thing. I've never seen it since, and I hope I never see it again. I started thinking about crazy stuff. But I was thinking like, ooh, that's alien. What's going on? I'm always, and that was when I was at the clinical at St. Joseph. So you know, when there are things that happen sometimes, I just know I'm gonna go in the room and the cross gonna be upside down. Because they have the, you know, crosses in every room. I said, one of these days I'm gonna walk in here, boy. I'm gonna roll right out. All right, so then we have pneumonia, one of those common things that can happen to patients. All right, so it's the inflammation of lung tissue. Now this can be caused by several different things, you know, so it's bacteria, viral, could be fungal, those types of things that happen with patients. But aspiration, high mortality rate, because essentially what you're doing is aspirating gram-negative bacillus into your lungs. So up there they tell you gram-negative is most severe, and that's because that bacteria can already grow without oxygen in the first place. So that's why it's so dangerous. And probably many of you during your lifetime have seen the Muppets. All right, so Jim Henson was somebody who contracted a pneumonia and was dead in 5 hours. So it always depends on the virulence of the organism that takes people out of here. Because most people with pneumonia get better, you know, but this was a person who felt sick. I mean, literally he got sick that morning and was dead in 5 hours. And they ended up with pneumonia. So community acquired means you have it when you come in the hospital or presentation within 48 hours. Hospital acquired is anything after 48 hours. Why that's a big deal is because hospital eats the cost, right? So that's why we were, you know, during COVID, we were closer to everything, you know, because we wanted to know if you had it before you came here or I gave it to you. And that's mainly because the cost associated with that now the hospital has to eat if somebody wants to say that for them. So then we have our ventilator-associated pneumonia, also a hospital-acquired infection. But remember, if you have VAP, that means you bypass all the protective mechanisms that are within the airway. So that predisposes this person to get pneumonia in the first place. So these are risk factors. So age 65 and over, recent surgeries, because if that you had surgery in your abdomen or your thoracic area, you're not trying to take a deep breath. You're looking at a nurse talking about, girl, bye. Stop talking about taking a deep breath. Also with altered levels of consciousness, seizures, people that can't control their airway. So altered level of consciousness for that, people who are coming out of, you know, drug overdoses, that kind of stuff, you gotta worry about that with the patient. We also see it with prolonged immobility, and then of course immunosuppression. That new group of patients you have with those immune modifying drugs, we gotta worry about those folks with this as well. So prevention, of course, is that we're gonna give vaccines, and there's a new advisory for vaccines. Right, so everybody's supposed to get a flu vaccine every year. It used to be that you gave this, your pneumococcal vaccine to anybody who was older than 2 years old and greater than or 65 or older, I should say, who, those were the advisories. So it's high risk for people who were 2. The advisory now is for anybody who is 19 or older with chronic conditions to have pneumococcal vaccine. So an asthmatic who is 19 years old should get a pneumococcal vaccine. So anybody with chronic conditions, diabetes, heart disease, that kind of stuff, the age now is down to age 19. Because what we're seeing is those are the people who end up in the hospital, who end up dying from this. So that's why the advisory has changed. So with VAP, of course, we want to have meticulous hand hygiene. You know I can't stand this anyway because it's such an info. But because ventilator-associated pneumonia means you have artificial airway, right? So when I was like, when they had up there that you suction only as needed, I was like, thank you, Jesus. All right. But we had done that years ago. Now what you also see is closed suctioning, so Ballard. We used to have to take everything apart, ambu the patient, and then do our suctioning of the patient. But like I said, people think I don't know how to do it. I just gag. You know, I can't help that part. But I've gotten better. But I almost quit nursing because in nursing school I had patients when I was going to the VA for a clinical 5 weeks in a row. I had patients who had artificial airways, and that last one, I just told my teacher, I said, this patient is disgusting. I said, I cannot do this anymore. And I think that's what started, because even now, if I have a cold and I cough, I'm like, to myself. But this particular, I mean, it was like everywhere. And it's, I don't mind taking care of a patient, but if I gotta do that, I just wanna pass out. And so she was, after I said, I can't do it, I gotta go home. And she told me, she says, but you don't understand. I was like, I don't understand, I can't do this no more, kind of thing. And she told me, she said, I was giving them to you because you were doing such a good job. And I was like, what? I said, well, can you give it to one of my classmates so they can do it? You know, kind of thing. She said, no, you did perfect technique. And I'm like, well, because you practice that because you want to do it right. You sweating like a fool and all this kind of stuff to get it right. But that last guy had stuff everywhere, and I just couldn't deal with it. I just like, and I know that was awful to say that about a patient, but that was it. I just couldn't do it. Now, I think back on that now, and I say, if I had worked in head and neck, I would be a size 2. Because I would never eat. Right? I couldn't do it. All right, so routine peptidoglycan prophylaxis, so patients are going to go on a proton pump inhibitor or H2 antagonist. We also want to get them off the ventilator as soon as possible. So sometimes you'll see patients, when we talk about weaning protocols, there are some people that do CPAP or BiPAP during the day, and when they get tired, we put them back on the ventilator. So that's what you're doing when you're trying to wean them off. See what they can do on their own, and then we try to get them off the ventilator as soon as possible. And early mobilization. Always in your head, think about 1 day in the bed is 3 days behind it. So when you let people just lay down, which is part of the reason why if you have people in your family or that you know individually, when people always talk about this person had a stroke and they want to send them home, no. And the reason you do that is because people at home, you love in your family, you're gonna try to do stuff for them instead of making them do things for themselves. And when you talk about patients in acute rehab setting, in the hospital, you have somebody that comes in PT and works in the morning and the afternoon. Acute rehab is a minimum of 5 sessions a day. So that's the person that you're going to try to mobilize them and do the things that they need to do. So always think about getting them up and moving is important. These are some of the signs and symptoms you see associated with pneumonia. Convective cough, tachypnea. As they get more and more consolidation, you see increased tactile fremitus. That's meaning vibration is going to be increased in those patients. Mental status changes because they've developed hypoxemia, you see associated with that. And then you may have patients who have hypoxia. All of these things are things you can see in the patient. What we want to do, of course, is hand washing, blood and sputum cultures. Isolate if we need to. If it's not contraindicated, you want to encourage fluids in those patients, mainly because it's thin secretion. Helps them cough up stuff a little bit easier. You want to manage their pain, and generally talk about pneumonias, that's when codeine comes into play. We give you a cough syrup that thin secretions, so it's bifenacin usually that you're going to see, that has codeine in it, so I'm giving you something that thin secretions, but also to help with your chest wall pain when you're talking about these patients. So monitor their O2 saturations, turn cough, deep breathing, using semi-spirometer. And one of the things about pneumonia that is sometimes people don't realize, even if you're a young, healthy person, a lot of people think they can go back to their usual routine after you're treated for pneumonia. Pneumonia is something that can put you on your butt, even if you're a young, healthy person. Especially for these young people that had COVID. You see them, they think they can go back and do everything they did before. Pneumonia is one of those things you have to amp up your activity. So it's going to be a progression of getting you back to your normal activity that you had before. But you want to make sure they're doing their turn, cough, and deep breathing. They're using a semi-spirometry. So these are some of your antibiotics your patients can take for pneumonias. In general, when you see patients, especially if they're hospitalized, you know how in the video they said put the patient on the Zosyn and vancomycin. That's usually the combination you see for patients when you're talking about sepsis. But the Zosyn is a 6th generation penicillin, so that's usually what you see for patients when they're in the hospital. If you have a patient who has a true penicillin allergy, meaning that they have anaphylaxis, urticaria, those types of things, that may also happen with a cephalosporin because they're cousins of each other. So if you have patients with a true allergy, you got to worry about that. And Zosyn is an anti-pseudomonal penicillin. Circle the aminoglycosides, because that's a medication that, yes, it kills off the bacteria, that can also kill off my kidneys, can also cause deafness, right? So those are the ones that even if I use them like I'm supposed to, can be problematic for a patient. And then our macrolide Biaxin is the drug that you see here. Never a first-line drug unless you have a person with other allergies, but it works as far as treating patients, but it makes everything taste metallic, so patients don't like taking it. It's a kind of big pill. What other thing do we treat with Biaxin? That girl bye. It's kills H. pylori, so we use it for peptic ulcer disease. So it's the antibiotic of choice when you're talking about patients who have peptic ulcer disease. And then fluoroquinolones, that's the cyprals that you have patients use. So a client who is 1 day post-op after left pneumonectomy is lying on his right side with the head of bed elevated 10 degrees. The RN assesses his respiratory rate at 32 breaths per minute. In what order would the RN perform the following actions? So now it's another putting things in order. So what's the problem at the beginning? What do you see wrong with this, with that patient? They're 1 day post-op after a left pneumonectomy and they're laying on their right side. Right? Because that's the only good lung you have. Why are you laying on it? Right? So I always think about good lung up when you're talking about a patient who had the other lung removed, because it has no way to expand the way you have this patient laying down. So even though you turn a patient, from side to side and that kind of stuff you're doing, you barely put them over on that good side. And it's mainly because you need to make sure that lung is up so it can get aerated, so that's gonna help with oxygenation for the patient. So what are we gonna do first for this patient? All right, so always think about the first part of the nursing process, assessment. So we're gonna measure their O2 saturation, then put them on their back, then raise the head of the bed, and then give them some PMS. So always think assessment is gonna guide your interventions, but for this one, we're gonna put them, you gotta put them on their back first, so then when you raise them up, that's when that person is actually gonna be able to breathe better. Allow that lung to re-expand, and hopefully, because you're giving them some pain medication, that's gonna help with that as well. Most of the time nowadays, in truth, thoracotomies get PCA. It's just certain surgeries that you're gonna see patients have. So the RN is orienting a graduate nurse caring for a client dependent on a ventilator, which actually by the GN demonstrates understanding of ventilator-associated pneumonia or VAP care. So this is select all that apply, but a positive focus because it tells you what do they get, what do they understand about VAP care. Do they administer a proton pump inhibitor as prescribed? Yes. Rinse his client's oral cavity with chlorhexidine every 2 hours. Yep. That's it. The same stuff you put on your skin as Hibiclens is the same stuff you do for oral care, but it's just a very weakened amount. So elevate the head of bed 60 degrees. That's the one they get you with, because it's 30 to 45, all right? And perform spontaneous breathing trial, and performs hand hygiene before and after. Those would be things that we do. So it's everything except that head of the bed. And it's VAP is specific, 35 to 45 degrees. That's how they get you with that particular question. Now, the one thing that's gonna likely be in the protocols that you see coming up for about intubating patients, one of the things that they have found in studies, now even though they talk about doing this chlorhexidine, and it'll be, they're putting it up here for every 2 hours. Some hospitals have it every 1 hour. You follow your protocol wherever you work. But there are studies that are coming out that say that we actually need to clean their mouth before we intubate them in the first place, because chlorhexidine is bacteriostatic and bactericidal. So that means it kills bacteria, stops bacteria from forming, so we actually have less VAP if we do oral care before we intubate the patient. So that's probably gonna be on protocols coming up if it's not already there in your hospital setting. So then we have some of these respiratory disorders. You don't want to call out now. So asthma is reversible, and then we have our chronic obstructive lung disease, which is kind of twofold. You have a patient who has problems with mucus production, so that's our chronic bronchitis patient, and then we have people that have alveolar dysfunction, and that's the patient who has emphysema. The majority of patients who have COPD have elements of both. So it's rare to have a person who is truly just emphysemic and a person who is truly just chronic bronchitis. They usually have elements of both. So what we see in patients when we talk about predisposing factors is with cigarette smoking, of course, that destroys all of your protective mechanisms, cilia and all that kind of stuff that happens with patients who smoke all the time, that predisposes them to developing COPD. We also see environmental and occupational exposure, because just from where you live can be more problematic for you. Even though Colorado is a beautiful part of the world, when it's stagnant air, Denver is like living in a trash bowl, right? Because all the pollution sits right on top of the city. But other than that, it's beautiful, but you can't breathe. And fat people have a problem, all right? At least I do when I go there. Now, the thing about it, if you live there all the time, you don't have that problem. But if you go there and visit, because you are, you really are a mile high up, so the air is thin. So just walking from the car, coming from the airport, putting your bag in the car, you're like, why am I short of breath? And you think about it, is it just because I'm fat? No, it's because the air is thin. All right, so it's funny because the Olympics start tomorrow. Well, they've started already, but the official opening series thing is tomorrow. And I crack up about it because Salt Lake City has been awarded the Olympic Games if they don't have this problem going on with the international doping thing. It's because my nieces and nephews are all in sports, so that's why I'm keeping up with that kind of crap. One of these days, one of them will make it there. But I thought it was funny. I said, well, we do, years ago in Russian countries, they said that they were giving their athletes blood products in order to help them perform better at the Olympics, blood doping, as we call it. And so I said, well, we do that, but legally. We send them out to Colorado Springs, because that's where the Olympic Training Center is. And if you're training that high, guess what happens to your RBCs? They increase, so you're doing it naturally, but it does the same thing. All right, so I think about that. So you have to be out there for a while for that to happen. But if you ever go visit, it's beautiful. And if you're a person that runs all the time, I'm telling you, forget it for a couple weeks. Because you just want to fall out. Kind of thing. All right, so genetic predisposition. We see that there's a predisposition, we talk about asthmatic patients, but there is a form of COPD also that is genetically transmitted. It's the alpha-1 antitrypsin deficiency that these patients have. And those are people that, normally we think about a COPD patient late 50s, 60s, 70s. These are people that can express disease in their late teens, early 20s, and most of them don't live past 45, 50. It's because they have such an aggressive form of the disease. All right, so our chronic bronchitis patient, this is a sputum person. They're coughing up stuff all the time, right? And so some of them are very nasty. And I don't know if it's just because they can't breathe or what, but they are, sometimes you'll have patients. I had a man that was coughing up and spitting on the floor all the time, like, look, if I fall in this, you know what's gonna happen, right? I will be falling out because there's sputum all over the floor, but then of course I'm gonna end up with a trach because I'm gonna get injured and I'm gonna have to think about all the sputum all over. So I was just like, they do stuff that makes you crazy. But they are chronic sputum production, and it's because over time the mucus cells within the airways get bigger on top of it. So not only are they producing more, but the cells get bigger, so it constricts the airway. All kind of things happen with these folks. So they end up with chronic hypoxemia. They can also develop cor pulmonale, which is similar to what you see in a patient who has right-sided heart failure. So this is what you're gonna see, the CO2 retainers, exacerbations usually because they have some type of infection, and their response to low O2s is different from ours. When our O2 goes low, it stimulates our drive to breathe. If we give them too much oxygen, they don't breathe. Okay, so we have to be careful about that. So with our emphysema patient, this is a person who has a problem of the alveoli. And so what they do is they actually stretch out but don't recoil. And so eventually they need more space. So that's what you see in the patient, the barrel chest. They have a lot of work of breathing, so they're always puffing along when you see this. And of course, that's energy expenditure. So those people tend to be spindly in their arms and legs and that kind of stuff. So this is what you see, air trapping that happens in these patients. And the AP diameter goes away because usually you're half of what you are sideways. When you talk about doing an emphysema patient ends up being the same front as they are sideways. And I always tell people, think about your people in famous people. They always want to do a picture like this because they look skinnier, right? Because if you're looking at somebody from the side, they're always going to look like they're small. So these are things that we see on assessment of the patient. For our bronchitis patient, you may see that right-sided failure, and that person also has cyanosis and distended dick veins. Our emphysema patient, kind of told you before, is their pursed lip breathing always, they're not cyanotic, but they're thin because of energy expenditure. When you listen to their lungs, the bronchitis patient can do pretty much everything. When you talk about your emphysema patient, it sounds more like trapped air, distant, quiet, almost a timpani sound to when you listen to their lungs. And sometimes they can have wheezing as well. What we want to do is, of course, try to keep their SAO2s greater than 90 and their PaO2s greater than 60. Now, one of the things that happens with these patients is that we see that their quality of life is improved by using oxygen. So, you know, there's parameters that people have to, they're not gonna ask you that on your NCLEX exam, but just know that you have to, there's activity kind of things that we look at, how low the person's oxygen goes so we can give them home oxygen therapy. But what we have found is if they're on long-term therapy at home, they're able to do some of their own ADLs, they can clean their houses a little, they may fix their own food. So overall, they have a better quality of life by having oxygen at home. Now, of course, you know, some of these people still smoke, right? I had a patient ask me that one time, well, what am I supposed to do if I want to smoke a cigarette? I'm like, you should be giving up these cigarettes, but you know they're not. I mean, they do that. And I said, well, I'm gonna tell you like this, because people call oxygen as an explosive gas. What oxygen really does is make things burn quicker. So if you catch on fire, that's the end of you, kind of thing. So I'm like, don't be doing that. You know, if you're gonna, because people are gonna do what they're gonna do. I always tell them, if you're gonna smoke, then you need to go somewhere away from your oxygen and smoke. And just when you come back, put it on. Breathe is short. They're gonna put it right next to the door so you can get it when you come in. But people are gonna do what they do. And that's just the end of that whole smoking thing. So monitor for signs of fluid overload, pursed-lip breathing, you teach about them. And really what you try to do is make sure they limit their exposure to infections, because that's what ends up causing the problems the most of the time. They get something, a little upper respiratory infection, and they end up in the hospital. So a client with pneumonia has impending respiratory failure. Which set of ABG values demonstrates respiratory failure? Y'all know that's lunchtime.